Good evening, everyone. If you'd like to type in the chat and let us know where you are physically, where you're joining us from, we're always interested to see what colleagues are in the room and where they are. Feel free to put that in the chat. All righty, I would like to welcome everyone to part 2 of our Healthcare Educator series. This session is entitled You, the Preceptor, Teaching Effectively at the Bedside. I'm Donna Murray. I am the Senior Director of Admissions and CASPA for PAEA, and I'd like to welcome everyone to this session this evening. Let me start with introductions of our facilitators. This evening we have Professor Andrea McKinnon. She is an assistant professor with the Wake Forest PA Studies program. She completed her Bachelor of Science degree in biology at Florida State University and her postgraduate work in microbiology and immunology at UNC Chapel Hill. Professor McKinnon is a 2015 graduate of the Wake Forest PA program as well. Professor McKinnon also completed a surgical fellowship in otolaryngology, head and neck surgery at Wake Forest Baptist Medical Center, where she continues to practice. She has lectured on several topics since joining the Wake Forest PA program faculty. She's been a champion for DEI within the program and currently serves as co-chair for the DEI committee with the North Carolina Academy of Physician Assistants. Professor McKinnon has been an advocate for inclusion of DEI in the curriculum at Wake Forest and models for her students and colleagues what it means to be a Jedi warrior. What you will bear witness to during the 4 sessions of the webinar is the Jedi warrior's vision for increasing diversity in front of the classroom, as she believes that representation matters. The webinar series is the brainchild of our colleague Andrea McKinnon, and I would like to thank her for her vision as we join her and Dr. Atrina Dawkins for what I believe will be a game changer for all of us. Dr. Dawkins is a graduate of Wake Forest and holds a bachelor's degree in biology. She also earned an MPA in nonprofit management from High Point University. In May of 2018, Dr. Dawkins earned her PhD in leadership studies from the North Carolina A&T State University. Dr. Dawkins is currently the program manager for the orthopedic residency program at Wake Forest Atrium Health. She has served in several capacities as she has focused her efforts on diversity, equity, and inclusion, both within the Wake Forest community and nationally. During the course of her career, Dr. Dawkins served as a member of the Diversity Celebrations Committee, chair of the Residency and Fellowship Administrators, and a voting member of the Graduate Medical Education Committee. Dr. Dawkins is an affiliate member of the Maya Angelou Center for Health Equity and the founder and director of the Kennedy Hopkins Scholars Mentor Program, which was created to facilitate mentoring opportunities for underrepresented minority trainees at Wake Forest Baptist. On a national level, Dr. Dawkins serves on the board of the Association of Residency Coordinators in Orthopedic Surgery and is the first African American female to hold the post of president of the association. Dr. Dawkins is committed to advancing mentorship, research, and collaborative relationships to increase diversity and a more culturally competent and inclusive workforce. We have a little bit of housekeeping that we want to attend to before we get started. This web series has been approved for Category 1 CME. To be eligible for this CME, you have to attend the live sessions. CME certificates will be sent after post-webinar evaluation is complete, and be sure to log your CME with NCCPA. And with that, I will turn it over to our facilitators for the evening. Professor McKinnon?
Thank you for that wonderful introduction. Hello, and welcome to part 2 of the 4-part Healthcare Educator series. We are especially grateful for the opportunity to specifically encourage and equip Black or African American, Hispanic or Latinx, Native American, Alaskan Natives, and Native Hawaiian practitioners with knowledge, resources, and support as you enter and continue on into the world of healthcare education. I believe these practitioners, designated as underrepresented in medicine, deserve special attention because PA programs are seeking to recruit and train a more diverse cohort of PA students, which we project can lead to an eventual positive impact on the social drivers of health plaguing our communities. I'm going to reference PAs today, but the information shared in this talk can be useful for even nurse practitioners and our physician colleagues. The graphic on this slide is an overview of what we will cover in this talk. I will start with a bit of introduction. The bulk of our time will be spent defining the role of the preceptor and how to meet your learner where they are as they progress through their clinical year. Then I will discuss the impact racially diverse preceptors have on the learning environment before I turn it over to Dr. Dawkins. And she will introduce a star-studded cast of experienced preceptors who will answer practical questions and share with you how precepting has been for them as a person of color. You will see this bar at the top of each slide. The green color will signify where we are. I have to start by giving a huge shout out to the Physician Assistant Education Association, or PAEA. They designed the Preceptor Orientation Handbook years ago, and it was updated in 2021. It is packed with tips, tools, and guidance written in a way that is easy to digest and apply while operating as a preceptor. This handbook is the fruit of many hours of work by more than 20 dedicated faculty and staff. So I want to acknowledge that and ask you to take advantage of it. If the PA program you are precepting for is a member of PAEA, and most are, they will have access to this handbook. They can send you a customized version of it to help answer questions regarding a long list of topics that I just don't have time to cover in this talk. Core competencies we expect new graduates to have, student responsibilities, liability insurance, and how to prepare yourself. How to prepare your staff. It is a gold mine. As a preceptor, I found it to be an invaluable resource. A lot of what I learned and much of what I'm going to share with you tonight comes from this handbook, and you will hear echoes of that throughout tonight's presentation. All right, so let's get to it. You are interested in becoming a preceptor to medical learners in the future, or you are already precepting and you're looking for ways to supplement your skills. This means you are joining us under the umbrella of healthcare education. Our panel will talk to you later about their experiences while serving in this role. But before we go there, I'm going to tell you that anything worth doing will be hard. That's something my dad used to tell me all the time. I'm sure you all have heard this saying as well and kind of know it to be true from experience. So I'm not going to sit here and tell you that precepting is easy, but I am going to say it is rewarding. Before we talk about all the semantics of being a preceptor, I want to ask you to spend a moment to reflect on your why. I believe that if you know why you want to precept students, why you feel the need to invest some of yourself into the generation coming behind you, then you will not only do it, but you will stick with it. Now, your why is not something I can put on a slide. You have to find that out for yourself, but I'm going to share mine with you. After I finished my fellowship in otolaryngology, I did something that my elders told me I should do after every accomplishment: reflect and give thanks. So I was reflecting on the people who invested so much of themselves in me, those people who helped to form my personal and professional identity. And I was so grateful to them. At Wake Forest, we have 10 rotations in the clinical year. And I wish I could put all of their faces up on the screen because I learned a lot from each of them, even if it was messy. I learned from the quote unquote bad preceptors as well as the good ones. Tonight, I'm highlighting these three educators who not only taught me medicine, but also implanted pearls of wisdom I still carry with me today. Lori Cox on the left side of your screen is an OBGYN nurse practitioner. Jeff Henshaw in the middle, he's a lead PA in the emergency department. And Dr. Brown is a head and neck surgeon in the department I ended up taking a job in after I completed my fellowship. These three people, in their own way, modeled what a leader should be in the clinical setting. They modeled patient-centered practice and how to respectfully collaborate with our interprofessional team members. I learned how important it is to know your staff and show gratitude for what they bring to the table. And the list goes on and on and on. So much of what I learned from them was on my pants, but really a lot wasn't. I felt the need to precept because I wanted to take what they taught me and pay it forward. And I wanted to precept because I didn't have a chance to rotate with a preceptor that looked like me. Out of 10 preceptors my clinical year, none of them looked like me. That sense of belonging and ability to let my hair down and just have a real conversation with a provider who may have traveled a similar road to mine, I didn't have that. And when I think about my white classmates, I realize many of them may not have had the opportunity to learn under racially diverse preceptors either. They lost out too, because racially diverse preceptor enriches the clinical year for everyone. We had a shortage of racially diverse preceptors back then, and we still do. I felt that if I wanted to change that, I had to do more than recognize the problem. I had to do more than complain about it. The change needed to start with me, so I became a preceptor. Now let's dive into the role of the preceptor, which folks cannot be overstated, because it's the preceptor that takes the student clinician and molds them into a full-fledged, fly-on-your-own PA. We all know that you really don't learn medicine until you start taking care of patients, right? So the first thing is we can't precept and expect our learners to only shadow us. That is not how they're going to learn. Don't get me wrong, if you're running behind or maybe it's their first day with you on rotation, it's appropriate to have the learner come in with you while you see a patient. But if you do that, find ways to include the learner. If you're doing an exam of the patient's oral pharynx, for example, you may say, I want you to notice how I avoid gagging the patient and how I determine if the oral mucosa is dry or not. Also consider talking through your rationale with the learner in front of the patient when performing the HPI. But really, folks, the learner needs to see some of our patients on their own. They need to practice taking a focused history, performing a physical exam, and practicing their diagnostic skills on actual patients. If you are able to get the learner EMR access, have them practice writing patient notes and give them some feedback on it. The learner should also have the chance to present the patient to you, complete with an assessment and plan, because that's when you really grasp how much they know and you get a clue as to how strong their clinical reasoning skills are. When I first started precepting, I would ask questions throughout the learner's oral presentation. And then before they really had a chance to think and answer the question on their own, here I was trying to answer it for them. And I remember I used to hate that when I was a student, and here I was doing it to others. But I would get behind, I would start rushing, and before you know it, I'm lecturing them and not asking them, not guiding them, helping them to develop their own clinical reasoning skills. Here is a tool found in the Preceptor Handbook that helps us all with that. Say your learner is presenting a patient to you. The patient is a 22-year-old with sore throat. The learner tells you the HPI and pertinent exam findings, but then they stop short of the assessment and plan. The first step on the 1-minute preceptor tool is to get a commitment from the learner. Ask them, what do you think is going on with this patient? What do you think we should do? Let's say your learner says, well, I think she has a paratonsillar abscess and it needs to be drained. Okay. Now, even if the learner gave you the right answer, you need to know how they got there. That's the second step. Probe for the supporting evidence and ask them, what in the patient's HPI and or exam support that diagnosis? That is when you get a glimpse into their clinical reasoning. Listen, tease apart things they thought about and things they may have missed. Step 3 reminds us all that positive reinforcement is how we reinforce the behaviors we really want to see. First, you need to find something to applaud, but be specific about what you are calling out. And step 4 is where the constructive feedback comes in. In the course of the day or even the week, the learner will leave something out or make an error. We need to call that out too, but give guidance when we do it. Maybe the learner wants to increase the patient's blood pressure medication for a patient with poorly controlled hypertension. You can tell them, yes, I agree that the blood pressure needs to be better controlled, but we should ask Ms. Dane if she is taking the medication the way it was prescribed before we think about just increasing the dose. And the final step is to teach them a general principle. Leave them with a pearl of wisdom as often as you can. This is when you get to shine as a preceptor and teach a little bit more. Share things with them that they may or may not learn in a book that you think they should carry with them. So you may have a patient who your learner has diagnosed with a sinus infection, but the symptoms started just 2 days ago. The learner tells you they want to prescribe antibiotics when you know you need to lean towards conservative treatment because the likely pathogen in this scenario is likely a virus. So you can say to the learner, knowing when to prescribe antibiotics for a sinus infection can be tricky, especially when the patient is demanding it. Let's review the clinical practice guidelines together. Now, it did take me some time to explain this tool, but trust me, when you use it, it really just takes a minute or two. Now, y'all know we are going to teach more than medicine. The learners will be watching you and seeing how you collaborate with your physician colleagues, your secretaries, your front desk staff, your nurses, social workers, the list goes on. We are really teaching team-based care here. You are also helping them build their emotional intelligence, which is defined as the capacity to best handle interpersonal relationships. It speaks to the learner's ability to take feedback, which we know is a skill that needs to be cultivated in all of us. You have the ability to help the learner with all of that. And we can't stress enough the patient's role in this. When you allow the learner to see some of your patients, the learner has a chance to hear the patient's stories and really feel and understand that the patient is more than a diagnosis. You're going to help them build that empathy that we want to see in them. In this way, the patient is a teacher too. I don't take for granted that any of my patients will allow learners to see them. I try to ask for permission first, and I always thank them for being part of the student's learning experience. Okay, so you want your learner to grow when they're rotating with you. How do you do that? Well, you need to know where they start from first. So get to know your learner early. You can do this by having them complete a questionnaire before they start their rotation with you, or you can meet and chat with them on their first day. Things you want to know are like, what type of rotations have they completed so far? What did they do before they went to PA school? What are their interests? And I think most importantly, what do they hope to get out of this rotation? Based on what they tell you, set and communicate realistic goals. You want to tell them how many patients they should see in a day, for example. Do they perform the entire physical exam or do you want them to skip certain parts until you come into the room? Tell them what you want their oral presentation to sound like. What do you want it to look like? So, you don't get a 10-minute oral presentation. We don't want that, right? The learner can bring a lot of value to your practice. By the end of the first week, depending on where they are in their training, they can help you expedite your practice. So set them and yourself up for success. You should keep in mind that preceptors push for progress, not for perfection. And the learner should not expect themselves to be perfect either. We want to provide excellent care to our patients, and being vulnerable enough to say that you don't know something is sometimes better than pretending you know everything and hurting a patient. This is their time to be vulnerable and seeing that it's okay to ask questions. In their time with you, give them constructive feedback as often as you can and be specific. If they're having a hard time writing their notes in a timely manner during that first week that they were with you, but now doing a much better job in the second week, tell them that. Everybody likes to have a pat on the back. But then they still may need to work on documenting rashes, for example, within the physical exam. Tell them that too. Keep giving them a goal to strive for. When a student rotates with a racially diverse preceptor, you could be a much needed source of inspiration, motivation, and create a general sense of belonging for them. The bar is not lowered when we have a person of color with us, but when they're with you, a weight can be lifted off of their shoulders. Some words or phrases don't have to be explained, and that fear of being judged is just a little less when you are working with someone who looks like you. But I'm going to tell you, everyone benefits because of your lived experiences. You are uniquely situated to promote the understanding of certain cultural and health beliefs, which needs to be translated to all PA students if we really want to make headway and mitigate these healthcare disparities. Like I said in the last webinar, literature shows that the impact we have extends past race and ethnicity. It includes socioeconomic status, military status, and sexual orientation. And I would argue that practitioners of color are more likely to discuss healthcare disparities in marginalized populations in ways that do not propagate bias. Now, I know that we have allies listening in on this webinar. We need you on this journey with us too. The Preceptor Handbook speaks to that. It says that all preceptors, regardless of background, should look for ways to expose learners to patients with diverse backgrounds, habits, practices, beliefs, and values. So as time allows, every preceptor should engage the learner in dialogue about those encounters, allowing both of you to challenge your own beliefs and reflect on how those beliefs can impact our patients. To our allies, I know that we are all at a different place in our journey. I just ask that you stay in the fight with us. So thank you all for listening. I just want to get you all warmed up for this all-star panel we have lined up for you tonight. I'm excited to get them on the screen so you can hear from them. I'm going to hand the stage over to Dr. Dawkins to do the introductions. Dr. Dawkins, take it away, sis.
Thank you so much, sis. So I have the pleasure of introducing our star-studded list of panelists, Dr. Shalitha Wynn, Oni Moma, and Kashif Creary. Before I introduce them, however, I want to remind our audience to please enter your questions that you have for the panelists at any time into the Q&A section and not into the chat. Dr. Shalitha Wynn has worked clinically as a PA for the last 17 years in a variety of roles, including inpatient at the Cleveland Clinic and Wake Med hospitals, outpatient work at her own private practice, and most recently in urgent care with Wake Med. She has served as a clinical teacher for many years and won Wake Med Campus Preceptor of the Year at Campbell in 2019, just before her transition from full-time practice to PA pre-clinical education. Dr. Wynn will be taking on the role of Director of Clinical Education for UNCPA in the fall and is looking forward to bringing the experiences she has as a clinical teacher to that role. Oni Moma is currently in an orthopedic surgery and sports medicine PA. Prior to becoming a PA, Oni spent 3 years in the NFL, and then he found his way into medicine. Oni is passionate about treating patients and mentoring the next generation of PAs. Kashif Creary is currently the Assistant Director of PA Studies at NYU Langone Hospital, Brooklyn. PA Creary also serves as the chairperson for the NYSSPA Diversity, Equity, and Inclusion Committee. Before NYU, PA Creary worked for the private and public sector, but spent many years working in Queens Health Network, where she gained a greater appreciation for working in underserved communities, implementation of operational solutions to improve patient care, quality, and safety initiatives to provide safer care, as well as caring for survivors of sexual violence. PA Creary's administrative career has included a focus on clinical education, including the use of simulation training, and likes to serve as a student preceptor. That said, we'll go ahead and jump into our questions. So the first question is, and I will pose it to Oni, Kashif, and Dr. Nguyen in that order. There are people listening who are still on the fence about precepting. Andrea spoke earlier about knowing your why. Can you all share your why for precepting learners? Ani.
Thank you. And that was a great introduction. Thank you so much. Right.
Welcome.
Knowing your why, for me, when you know your why, it comes from experience. And from that experience, it gives you some kind of purpose. And knowing your purpose comes from the history that you came from, the experiences. So my experience in the lead up, playing football, coming out, trying to figure out what the next step is. It took me shadowing, going to get an experience of what I want to do, going to PA school, and having preceptors pour into me for me to be the kind of person I am today. Without preceptors, without mentors, without coaches, without people telling me, hey, you're more, you're better. And when you get there, have a little more confidence, be a little more communicative, be outspoken. Hey, you're doing the right job. You know, that feedback Andrea was talking about, super important. So having those preceptors giving you what you need to get to where you're going to go gives you that purpose to kind of give the same thing and give back, right? So that's my why. Some people poured into me, and now I have a purpose to do the same thing. Thank you.
Thank you. Kashif?
Hello, everyone. I'm glad we can have this conversation about something that's really near and dear to my heart. I mean, the obvious reason is advocacy for our profession. That's why I'm a preceptor. You know, being a preceptor does mean you have to invest time in your knowledge, your insights. I would, though, precept anyone who's interested in medicine, you know, connecting with people that are interested in entering medicine. We need to demystify the process, explain our wins, our battles, how we persevered, and at the end of the day, the satisfaction that we get from doing what we need to do. You know, we really need to talk to them and relate to them as human beings, because some people are just intimidated about the process and how we got there. So I think that's like a basic place to start. And even students that make it, you know, while we're precepting them, are still oftentimes, I find, extremely frightened. So you take that moment to connect to somebody, you take a lot of the angst out of them as human beings, and then they can concentrate on learning. If we want to create a culture of safety and fostering future learners, we have to show them how to create and maintain a great medical community. That's that human side of what we do. You know, other professions, if you look at the medical track or the nursing track, it's really built for success. They have very strong precepting models. They have protected time. They have dedicated teachers. They have residencies and fellowships and simulations. They celebrate their milestones that are accomplished. They facilitate events and community atmosphere. A lot of things are built in to sustain their upcoming counterparts, right? And furthering the profession. As established professionals, we know what it took to get there. We can share these tidbits with the students. I remember, and I never forget, part of being a preceptor is I never forget what it took for me to get there. And I always say to myself, is this where I was at that point, right? And I try to connect with them. I try to relate. What should I know at this point? What wouldn't I know? And then I try to ask them, okay, what do you need from me? What do you expect to get out of this rotation? I try to personalize it as a little bit as a preceptor so that it's more meaningful to them. We all sometimes forget how much we memorize. You have to memorize so much. You have to learn so much. But now connecting the dot to the human that's in front of them, treating them is a very different skill set and a process that you're going to walk your student through. You're going to say, you approach the bedside. What's the first thing you see? That's not what's talked about in the textbook. Does that person now look like their vital signs? Think what has changed? What's the family dynamics? What else is going on in there? Okay, so what's the first? You're going to really go through with them how to practice medicine. And as a preceptor, if you love what you do, you try to convey that to them so that when they're more passionate about it, they treat their patients better, they connect to their patients better, they're better to their colleagues, and that helps to bring that society that we want. We want a good, safe, comfortable environment for everyone to learn, because medicine is evolving all the time. So we want to create that really good medical community. And that's part of it, is fostering the sense that this is ongoing. We're always going to be learning. And so we teach each other. And being a preceptor, believe it or not, I really like it, because sometimes these students, they come out with really good facts, new things, the new app for that. It's wonderful. Thank you.
Thank you, Kashif. Dr. Nguyen?
Yes, hello. Good evening, everyone. Very happy to be here. And thank you, Dr. Dawkins, for the beautiful introduction. This has been great so far. So when I think about my why, I really have to go back probably all the way to childhood. Teaching was always a career possibility for me. So I kind of toyed with the idea of being a teacher versus being in medicine, I think, up until a certain point, and then I became committed to medicine. So the marriage of those two things, I think, was always just kind of a natural next step for me. But really over time, throughout, my experience in the profession, I've really just felt humbled by the experience, felt like it was a calling to me, and that I wanted to give back at some point. Definitely, I think probably around my 5 to 10 year point, I was really, really convicted to make myself available to others. And I think when we think back to the Hippocratic Oath, in some of the language in there, it always struck me that part of the commitment in that oath was not just to patients, but to also teach the next person who wanted to learn the craft, and that was also a part of our duties. I think that if anyone feels this calling to be drawn to human suffering and try to mitigate it and be a part of that process, whatever your discipline is, that should be supported. And so preceptorship to me, I don't think was ever something that I had to decide to do. Just where I come from and the love that I've had for the profession and all the opportunities that it's given me, I think that it was just a natural next thing to do. It's almost unfair, I think, as much as I wanted to give back, I think I have actually probably gotten more from it than I've invested. So that would be my why.
Thank you. And thank you all, each of you, for that authentic response. A lot of practitioners may want to precept, but work in a really busy clinical practice. They may think it's not practical to take a learner. All three of you work in a busy practice, but also precept learners. Can you share tips or pearls of wisdom that might convince our audience that they can do it? Like starting with just 1 or 2 learners per year. And I want to pose that question to Dr. Nguyen first, and then to Kashif.
Sure, fair question. Logistics matter, right? So, you know, in one of the more recent schools that I worked with, when it came to their learners, um, when I first started working with them, I didn't intend to. So there was a student that approached me because their preceptor had to go out unexpectedly, and she wanted to work in the field, or in the area that I was working, and didn't have a chance, and was looking for someone to help her out. So that year I just took one person, and the intention was not to continue teaching. At that point, it was just to help this one student out, and then we gave birth to a love, and connected with the school, and the rest, as they say, was history. But to start out, I really didn't have a ton of bandwidth. So I worked with the school, and I was honest about what I could do, and I was honest about my concerns for the students. Right? If it were a time of year when we were really, really busy, I didn't feel like they would have an optimal learning experience, and I was honest about that. So I worked closely with the coordinators to come up with expectations and a schedule that worked. It was better for me to set parameters around when I could take someone, when I couldn't, and also where they were in their journey on their second year. I felt like the place where I was working was a wonderful place for people who had already gotten their feet wet, and that it wasn't necessarily a great first, second, or third rotation. But if they had a few under their belt, they could really get in there and see all kinds of things. So I think that time doesn't have to be a limiting factor. You can be honest about what you're able to do, and most schools are willing to work with you within those parameters to optimize opportunities for learners. Thank you.
Thank you. Kashif?
Hello. So I agree with what Dr. Nguyen said in terms of setting parameters. You definitely have to speak to the school in terms of the number of students that you can take, the times, the schedule that they have to meet, and the expectations of the rotation. I'm in an emergency department, so I definitely have some flexibility, but I know how many students I can precept at a time, to make it really effective and meaningful for them. So for each practice that, and each person, that will vary a little bit. The other thing is, if you have other clinicians within the practice, do you have to absorb all of the students' time? Can you share and have the students rotate with other people so they can have different experiences and different exposures and approach? So I tend to have the students spend about, for me in the emergency department, about 1/3 of their time with me. And then I also have them rotate with others. Some people have students only rotate with them. You have to decide what best works for you. But the important thing is to make sure that you have the students see patients, you go through the whole thing from history and physical and the treatment plans, understanding, watching them go through the process so they get it and they understand, and they're learning how to practice medicine. I think that is, for the most part, from all my years of precepting, most students, that's what they really appreciate. They want to come out of the rotation feeling like they're better for it, and they practice a little bit better. Thank you.
Thank you. Thank you. And so we'll take just a pause on these questions, and I wanted to check in with Andrea to see if there have been any questions placed in the chat. Actually, I'm sorry, I'm checking with Donna, Dr. Murray, to see if there are any questions in the chat.
So we do have a question in the chat, and I'm going to open this up first to Andrea and then to the panel. So how many years after becoming a new grad did you feel comfortable, or do you recommend precepting students? And this is from Savannah Fusaro.
I get that question a lot. So I think it's different for everyone, but for me, I waited a year. So it was almost a year on the dot where I felt like I was ready enough to take on that mantle because of my second why, right? I knew there weren't preceptors out there that look like me. There were none in ENT that looked like me. People say I'm a unicorn all the time. So I knew the gap that I would feel if I was going to, precept. So I waited a year and I started slow. I didn't take 2, 3, students every rotation. I did a little bit at a time. And then I just kind of got my confidence, built that up, and went from there.
And if any of the panelists want to jump in and respond as well.
Just real quick, a response. I'm in a subspecialty in sports medicine. So once I first started as a PA, knowing that my private practice accepted students from all over Lehigh Valley, Pennsylvania, I was like, when can they start? Right away. Because such specialties, now everybody has a chance to be a part of those. And when they ask, and now a lot of people want to, in my area, doing a lot of precepting. I was like, if I'm the only one, just bring them in. I'm learning, they're learning. I'm acting like I know everything, right? But at the same time, they're learning from me because I know a lot more than they will ever know. You know what I mean? So being in the subspecialty, I just felt it was an obligation just to get them in the door so they can get those hours, get that experience. That was for me. And that's my experience.
Thank you. Dr. Murray, are there any, Kashif?
For me, it was about 2 years, and only because emergency medicine, I wanted to make sure that I was comfortable enough in almost any scenario as I rotated through the emergency department that I could do justice by having the student come with me. And so after about 2 years, I felt confident enough to do that I had rotated enough through the critical care and fast track and then through the moderate area so that I can really be helpful to them. Thank you.
Thank you. Okay. Dr. Murray,
And I'll
are there?
chime in and just say, for me, it was my second year out of PA school. It's a really individual decision, I think, your level of comfort.
Yeah.
Are there any additional questions at this
There are
time?
no other questions in the chat.
Okay. So
I think, sorry, I think I saw something about an NP being able to precept a PA. Am I wrong?
Yes, that was
Yes.
the question that was put in the chat.
And I
And the
think-
answer is yes.
Sorry.
Cool. No problem.
Okay,
Okay.
everyone, feel free to put your questions in the Q&A, please.
Thank you, Dr. Murray. Andrea spoke about creating realistic expectations for the learner when they rotate with you. What are some expectations you have for your learners early in their clinical year versus when they are closer to graduation? And I will pose that to Kashif first and then to Oni.
So because I mostly precept students rotating in the emergency department, although now I precept them in four different groups of students, I've always said, if you're going to rotate in the emergency department, it really needs, and this is something that Dr. Nguyen was alluding to, it's not a good idea to have them rotate until they've at least had 3 to 4 rotations. It's a harder rotation and I don't want them to be lost. But I also set the tone for them. I send out a templated email about some salient points and expectations. I meet them on the first day. This way they get to see me, I get to see them. We discuss the nuances of the department. I ask them if they have any questions. I ask them what their strengths and their weaknesses are. I tell them about some of the higher level things that they're going to be doing in the emergency department. And we try to set them up so that as they rotate through, they get to do a little bit of everything, and so that it's a good rotation for them. But definitely set the tone from them up front.
Oni?
100% agree. Setting the tone is important. So when anybody comes to shadow, the guy precept, I make sure I send an email that's indicating what I expect. When I first sit down with them, it's all about communication. I need them to speak up exactly what they're trying to achieve. And during the time we're working together and I'm precepting, for them to actually communicate in the beginning. Are they comfortable with closing? Are they comfortable with just retracting? Do they want to do more in the surgeries? What are we trying to achieve? Or do you want to learn different techniques? If you do, I have different techniques to take home that you can practice with. Just communicate what you're comfortable with and what you expect from that rotation. And towards the end of it, I expect them to know the responsibilities of what it takes to be an orthopedic surgery physician assistant, what it takes, because it's always the newest and greatest thing coming out. So I'm saying you're responsible to be on the CMEs, be on those seminars, go to those places to learn. Because as this orthopedic PA, there's a new knee, a new closure device. And also make sure they understand that medicine is a practice. And if you don't keep practicing, you're never going to be, you can't be mucky see, mucky do. You have to always continue to grow and not do the same thing over and over and over. So that's what I expect from the beginning and at the end, just to let them know that the growth is important.
Yes. Both great points. I was at a recent meeting, and it was an orthopedic meeting, and there were all kinds of vendors there that were just ready to interact with interns, residents. So definitely a great point. PAs are trained as generalists in their didactic year. So when they rotate in a specialty clinic, they may not have a deep well of knowledge. How do you prepare them for success and push them to grow while keeping the learner's confidence high during their time with you? And I think you all have alluded to that a bit, but if you could kind of elaborate more. And I want to pose that to Oni first and then Dr. Nguyen. Oni?
Definitely. So generally, when a PA comes out and let's say I'm never their first rotation, but I'm early in the rotation. And I love sports. I played sports in high school or in college, and I want to be in an orthopedic field. And I'm like, you really have to communicate, because if you don't know your anatomy from head to toe, if you don't know the muscles, insertions, and what to expect, the medical lingo that we're dealing with, just first communicate what we're doing. And begin, I refer to giving an outline. Say, hey, this is what we're going to be doing today. Here's our patient census for today. Just go over that. Let's see what you're comfortable seeing, and we'll just pick the 1 or 2 or 3 patients you want to go see by yourself. Let me know what you're capable, what you're comfortable with, right? And then come from that generalist mindset to say, okay, I had a shoulder surgery in the past, and I feel comfortable doing shoulders because I did a lot of research on them. Like, perfect. Let's start from there. Right? To get them comfortable with just doing the orthopedic tests, the physical exams, which can be intimidating, So, hey, show me what you know, right? So taking them from that comfort zone, putting in something that they are already aware of, and let's repurposing it to make them comfortable to get out of that generalist mindset and be more of a specialist mindset. That's how we do it.
Dr. Nguyen?
I think, sure, thank you. So I think my initial experience as a PA, my first job being in liver transplant, I felt like an imposter all the time. So I can really sympathize with students when they come into an environment and they just don't know where to start. But my goal is always just to get them to start, right? So as preceptors, we don't take responsibility for a person's entire education or even training them in any specialty. We are there to provide an experience and to provide guardrails. And if you show up every day and you are teaching and giving them the opportunity to interact and to grow their skills and have patient experience, that's the job. So my goal is always just to make sure they know more and have had more experience than they did when they came through the door. And we talk about setting goals. What do they want to get from this rotation? Typically, if they're rotating in a specialty, it's because they have an interest in that area or have worked in that area. And a piqued interest is half the battle when it comes to education. They are going to be more motivated to study and willing to climb higher heights. So, and also the number of times that the students interact with the material is important. So one thing I always encourage is, this is not the end of your day, right? If there are things that have piqued your curiosity, if there are things, questions that you've had throughout the day, and I've said, look that up, it's important to go home and to continue studying and layering the knowledge base in that particular area. And that also helps with success. So I think the biggest thing is allowing students to understand that they don't have to eat the whole roll in one sitting. That this is a layered and a spaced approach. And I don't carry the burden of feeling like I have to teach them everything. I'm just there to set the table for an experience.
Thank you. And I love how you said you provide experiences and guardrails and putting the accountability for the education on where it should be with the student. So thank you for that. And now we will pause again and see if Dr. Murray has a question. And actually, that will probably be our final question. Dr. Murray?
So we do have a question in the chat, which I love. Dr. Kim Stokes is asking, well, she introduces herself, of course, as a program director and former director of clinical education, and so am I. This is why I love this question. For those considering precepting, what type of support would you need from programs to encourage you to begin? So for the panelists, what type of support may have been offered to you?
I love this. I love that question. Um, so I came with the heart and the energy and the commitment to this, I think, and the love for the profession. But what I didn't know was pedagogy. Or anything about any sort of structured delivery of material. So the programs that I have worked with were absolutely phenomenal for providing that structure for me. Because you get someone in and you're excited and you're going, and it's like, have they learned anything? So I think that those things from the program are important. What are the things that this person, this student needs to leave this experience with? And you have to be honest throughout the rotation, right? Did they have the opportunity to see this? I work in urgent care, so I can't always control what comes through the door. And if they didn't, help me come up with different ways for them to get this information, even if they didn't see it. So very important to partner with your program. But the other thing is just difficult conversations and situations with students. And the programs can provide that sort of support, right? Like if something is happening that you may not understand, there's a communication issue, or maybe the student isn't moving forward kind of the way you set goals to do so. It's always helpful to go back to the program, right? They have been interacting with this person for over a year. So I think sometimes we feel as preceptors that we're like on an island, and we forget that we have an entire institution that is invested in this student that we are sharing, that can provide a lot of context and a lot of really good information to support both of us through the process if we'll tap in.
Thank you. And that definitely lifts the pressure off of the preceptors. That is truly a village. So I want to thank the panelists again for your authenticity, for your thorough responses. I appreciate this time together in this virtual space. And with that, I'll kick it to Andrea.
All right. I love that. Y'all can see why we chose these three superstars. We hope that you have learned from and been inspired by these three panelists tonight. They were wonderful. Before we close, I want to give you a preview of our next two sessions. Part 3 is entitled You, the Guest Lecturer, from the Clinic to the Bedside. It will take place on Thursday, May 11th. In it, you will learn the basic principles of learner-centric instruction and hear from another diverse set of preceptors who will share their experiences and pearls of wisdom with you. Part 4, entitled Building Your Network, will take place on Thursday, June 22nd. In that session, you will learn about the value of finding a mentor and why networking is important for building your brand. And we will split into breakout rooms, giving you the opportunity to meet educators from different parts of the US. If you attended the first session, please complete the post-session survey in order to get your CME certificate. And be on the lookout for the post-session survey from this session as well. We are excited to share that these recordings of all of these sessions, as well as other useful resources, will be available for you to access on the PAEA's all new BIPOC faculty development website. We are going to put a link in the chat so that you can save that and you can go and visit it. So that's all we have for tonight. Thank you for joining us, and we'll see you again on May 11th.
Thank you, everybody, and have a great night.
Thank you,
night.
everyone.